I'm an exercise physiologist by training with a nutrition background, but I do research, both nutrition and physical activity related research in dialysis patients primarily. And I'm going to focus mainly on the nutritional stuff today for a variety of reasons. It's kind of hard to do both in one talk, but I'm really going to focus on this peculiar condition as chronic volume overload in dialysis patients. And if that's not your cup of tea or anything that you really focus on, I do want to preface this talk. If you give me some leeway here and be patient, I think there's going to be some interesting things that I'm going to talk about that I think a lot of you will have some interest in, at least on some levels. Is we're going to focus on benefits of sodium restriction in particular related to chronic volume overload in dialysis patients, but I really want to emphasize how important I think sodium restriction is for a variety of different reasons I'll go over to many chronic conditions. So if you're studying diabetes or hypertension or multiple sclerosis, whatever your chronic condition you might be affiliated with or study, there's probably some pretty good reasons to restrict sodium. And some of the things that we've done, some of the struggles we've had to do so, there's lessons to be learned from that. But with that in mind, I do want to give a little bit of background and realize that most of you are not working in kidney failure. So what happens when your kidneys fail? A brief overview of things that happen. Well, the most common treatment for this is hemodialysis. It's a kind of a grueling procedure where it's inpatient, it's outpatient setting or dialysis clinics. Patients have to come in 3 days a week for about 4 hours to get their blood, drained, filtered, and put back in. And this shows somebody that's on a dialysis machine here. Imagine going there 3 days a week for 4 hours for this treatment. They're been described as their jail. There's a lot of comorbidities associated with this, so I'll get into. But one of the primary problems they have is, since they don't have any kidney function, very little, if any, urine is produced. And so there's this concept I'm going to keep coming back to, known as interdialytic weight gain. This is how much weight you gain in between your dialysis sessions, which is usually 48 to 72 hours apart. In the US, usually most patients gaining around 2 to 3 kilograms or liters of fluid in between their sessions. That has to get pulled off in a 4-hour session. So you gain 2 or 3 kilos, you got to pull off in 48 hours, and you got to pull that off in 4 hours. And that's a sort of a non-physiological condition that causes a lot of problems. One thing it does lead to this condition is chronic volume overload. You have too much fluid in your system, contributes to hypertension, left ventricular hypertrophy, heart failure, and cardiovascular mortality eventually in a lot of patients. But there's other comorbidities. Muscle wasting is very prevalent in dialysis patients. A lot of bone disorders, depression, cognitive dysfunction. And most of their medication most of their clinical management is pharmacological. They're prescribed on average in the United States 19 pills a day. These are phosphorus binders and hypertension medications and all kinds of things. So it's very difficult for them to manage. And it's also very expensive. In fact, it's the only disease where you're guaranteed healthcare coverage despite any pre-existing conditions you might have. And there's a long story of why that happened, but Medicare covers the cost of all these 550,000 dialysis patients we have at a cost of $93,000 per patient per year. So you're looking at $40-something billion, which is about 1% of the entire federal budget. Hard to believe, but that's what we're facing. And the fact of the matter is that dialysis, when they decided to pay for dialysis patients back in the 1970s, when they started this program, it was with the promise that these patients were going to be rehabilitated. And it was going to be a cost savings. We're going to rehabilitate these patients and they're going to be able to go back to work. And that just hasn't happened. And they don't feel they're being rehabilitated with their current treatment protocols. Another problem with the dialysis patients I'm going to focus on a lot is the renal diet. It's also been dubbed the art of restrictions. Just to give you a quick run through of what happens in the renal diet or what it's all about. First of all, protein is a little bit strange because before you go on dialysis, if you have chronic kidney disease, but you're not yet on dialysis, there's restrictions on protein to try to preserve kidney function. But once you get on dialysis, your kidneys are done. So there's actually changed to an increased requirement for dialysis patients to prevent muscle wasting. There's also a lot of restrictions on different nutrients such as phosphorus and potassium. Phosphorus is to reduce bone loss. Potassium restrictions are to prevent arrhythmias because these aren't cleared through the urine because not producing urine. So they have to restrict these in the diet. At least that's the thought. They also have fluid restrictions, which is kind of the bane of the existence of the dialysis patient. And this is to reduce this weight gain between treatments, or IDWG is interdialytic weight gain. There are sodium restrictions. They talk about this to prevent the thirst instead of just restricting fluids, but this is not the primary focus of the diet. The primary focus of the diet in dialysis in particular is restriction in phosphorus and potassium. And what this really looks like, where do you get phosphorus, potassium? From fruits, vegetables, nuts, grains, legumes, and dairy. So all these things that me and you think are healthy are at least on some level restricted in this population. So there's a lot of problems with that. Foods contain a lot of fiber, a lot of other micronutrients, a lot of good things are being restricted, and they end up, eating a lot of just, protein, chicken, steak, fish, things like that, and then a lot of processed grains, and they even asked them or suggested they should suck on candy during their dialysis treatment to prevent the thirst. So there's just some really odd things about the renal diet that I can't stand. And it's nonsensical. We'll say that the restrictions are not as prominent in pre-dialysis patients, but once you get to dialysis, they're pretty, difficult restrictions to manage. So the problems of the renal diet, first of all, the compliance is terrible. The efficacy isn't established. So there's some indications that outcomes might be worse in the patients that follow the renal diet most closely. Patients don't understand it because it is very complicated. And there's some indication you need teams of dietitians to actually implement this in the clinics. And so it's not real practical. And then you got this fact that the protein needs change once you initiate dialysis. You go from a low protein to a high protein diet, and that's confusing for some. And it promotes malnutrition because they don't know what they can eat. And so they oftentimes just don't eat as much. And also they have some anorexia because of their taste is they don't have they don't like the way food tastes, and they also just aren't hungry. And the fluid restrictions that they put these patients on are just inhumane. You cannot tell a thirsty person not to drink. It doesn't work. I mean, go to the movies, get some popcorn, and try not to drink something. It's impossible. And we tell them not to drink daily. So there's got to be a better way. And what we're really focused on, and I'll go into a lot, is a reduction, or trying to really focus on the salt and processed food, restricting that to prevent the thirst and allow them to eat real food. It's less confusing. There's a lot of other benefits I'll get into. So just a little bit of background. Why is an exercise guy like myself so focused on salt? Well, I want to have a nutrition background as well, but I am an exercise physiologist. But I was taught a very valuable lesson. At a couple of years ago, I had an NIH grant where it was an exercise nutrition related intervention. I was working at a clinic in Chicago. One of our patients was in our exercise group, and we were giving him a bike, and he was cycling during his dialysis sessions. And he was a 35-year-old African-American male, very typical, sedentary, obese, hypertensive, diabetic. And his interdialytic weight gain was about 5 kilos. So every other day, this guy's gaining 11, 12 pounds of fluid and then getting it pulled off in a 4-hour period. You can imagine that's got to be challenging. But he was in our interdialytic cycling group in this trial. I came into the clinic on a Monday. So he dialyzed Monday, Wednesday, Friday. And I discovered over the weekend, this guy had gained 15 kilos. So 30 something, 35 pounds over the weekend. And I couldn't believe it. I didn't know what had happened. Well, what had happened? I started talking to him. He said on Friday at dialysis, he had been cramping. When patients cramp, they give them saline to prevent the cramping, and drops in blood pressure that also occur when you try to pull too much weight off. And so, but saline makes people thirsty. And he told me that he was actually drinking he was so thirsty, he was drinking 5 2-liter bottles of Coke a day. And it was just such an eye-opening thing for me, because I was like, I'm putting a bike in front of this guy, asking him to pedal, we're giving him a little bit of protein. We have no chance of helping this guy if this is, what he's going through on a daily basis. So he finished the study. We didn't see any benefits, no improvements in physical function, no improvements in cardiovascular risk. And we took the bike away from him because the study was over. But he after a couple of weeks, he got bored and he wanted to start cycling again. And like, sure, why not? We gave it to him. And something clicked in the guy. I'm not exactly sure what happened, but he started cycling for about 1 or 2 hours per dialysis session. But he also just stopped eating processed food. Instead of leaving the clinic and going to McDonald's, he was starting to go to the grocery store more, cooking, shopping and cooking. And the guy lost 40 pounds and got a transplant. So this tells you, just how incredibly powerful this lifestyle factors can be for a dialysis patient. There's no drug regimen that could have done anything close to this to get this guy healthy enough to get a transplant, but lifestyle changes did. So our take-home message, my take-home message from this, what I learned is that comprehensive behavior change is what these guys require, not just sticking bikes in front of them or giving them a little bit of protein, but we got to do a lot more than that. Well, this was good for him, but honestly, my NIH trial pretty much failed. We had a 12-month interdialytic exercise and nutritional intervention, required protein supplementation during dialysis. Big, 100 dialysis patients we had randomized these 2 different groups, and the primary outcomes, there were no changes in physical function, no change in cardiovascular function. So I kind of jokingly say this was a waste of $3 million that I wasted for NIH gave me. But with a caveat, I say this is a caveat that many trials in dialysis patients fail. Drug trials fail, exercise trials fail, nutrition trials fail. Almost nothing works. And this gets back to my point about these patients don't feel like they're being rehabilitated. And they just don't get any better. And our trial didn't help most of them get better, except for a few these anecdotes I have from this one patient I just mentioned. But I did learn a few things along the way. And one is, as an exercise physiologist, should have known this in the first place, but you want to try to get people to exercise, we've got to do more than just stick bikes in front of patients and hope that they move more. We've got to work with them to do some other things, get them moving more by any means necessary. But I also really started to better understand the impact that chronic volume overload has on our patients, and that really started to understand how many of our patients had chronic volume overload. And if we don't control it, I can do any kind of exercise I want with these guys. It's never going to work. And we've got to get patients healthy enough to exercise, and we got to address this issue of excess volume. So I've been talking a lot about this. I want to dive into a little bit more what the problem is. So again, these patients are drinking excess fluid, and this increases blood pressure, left ventricular hypertrophy, cardiac dysfunction. And they have a lot of intradialytic symptoms also, like the cramping, fatigue. Because when you pull all this fluid off, it's like running a marathon. They just feel awful. And then they go home and they have to, they almost feel like hungovers. They eat poorly. They just sleep. Now they have sleep problems. It's just a really vicious cycle of, problems that lead to a sedentary lifestyle and bad dietary habits, all kinds of stuff. Well, how prevalent is it? It's hard to really know because it's hard to really measure precisely. But using biological impedance, there's some indications that prevalence about 25 to 30%. This is studies that have been done in Europe, but we know that that's probably inaccurate. These measurements aren't precise. There's some indication that prevalence in the United States may be around 80% or so. And this comes from, I'll get into this in a minute, but there's a group in Turkey that's really done a good job addressing this. This individual, Erkan Ak, has done a lot of these studies, and his take on this whole area is that if dialysis patients are on a blood pressure med, or if they're hypertensive, they most likely have chronic volume overload. Now, I'll show why he says that in just a minute. What can be done about it? The good news is they have developed a program to address this volume excess. That is, a volume overload has been nearly eliminated in about 90% of their patients using this volume control strategy that they practice in Izmir, Turkey. So if you don't remember anything else I talk about today, I want you to remember this first bullet here. about 90 to 95% of their patients have normal blood pressure with no medications. And if you compare the United States and most of the Western world, about 80% of our dialysis patients have elevated blood pressure, have hypertension with multiple blood pressure meds. So it's completely reversed. Their intra-dialytic weight gain is less than 2 liters per 48 hours. Ours is closer to 3. So we've got to pull more fluid off than they do during dialysis. Their systolic and diastolic function are relatively normal. Left ventricular hypertrophy and heart failure are rare. Mortality rates, half of what is the US. And they're not doing this because their dialysis is different. They dialyze just like we do, 3 days a week for about 4 hours per session. It's easier if you dialyze longer, daily, then you can control blood pressure better, but they do it just like we do. And the question, it seems obvious, why are we not doing this? And my answer I'll get to is it's really challenging to do what they do, but I've got some ideas on how to try to mimic what they do anyway. So how do they do this? They've got this comprehensive volume control protocol. It really is 3 primary components to it. The first thing they do, and this is really going to be really challenging in the US, is they get all their patients off of most of their blood pressure medications, if not all of them. And notice that when they do that, their blood pressure doesn't change. And the reason their blood pressure doesn't change when they remove these meds, a couple of reasons. One, because a lot of patients aren't taking the meds. And 2, if they are taking them, they're vasodilators and they're beta blockers and things like that. These are the reason their blood pressure is elevated is because they have too much fluid in them, not because of these other mechanisms that contribute to hypertension. The second thing they do is, and the other thing about these blood pressure meds is when you're on these blood pressure meds and then you try to pull fluid off them during dialysis, if they're on a beta blocker, they can't increase heart rate to maintain pressure. So the pressure really drops a lot and they get intradialytic hypotension. I'll talk more about that. If they're on a vasodilator, the same thing. They can't constrict to maintain pressure. So the second thing they do is they use, it's called persistent ultrafiltration. Ultrafiltration is a process of removing fluid during dialysis. So if you come into dialysis and you're 80 kilos, you leave dialysis, you've gotten 3 kilos pulled off, you're 77 kilos. What they try to do is they get them in there and they try to progressively reduce their post-dialysis weight to 76.8 and 76.6 and 4, and they slowly reduce their post-dialysis weight until they reach a normal blood pressure. And so they reduce post-dialysis weight slowly, and maybe they have to extend a few sessions or give some extra dialysis sessions to achieve this, but they eventually are able to achieve this in most of their patients. And the whole key to this thing is the third leg of their protocol is the dietary sodium restriction. They really focus on that. I mentioned earlier that we have, dietary sodium restriction is part of the renal diet, but it's not a focus. The phosphorus and potassium are the focus, not the sodium, because it's a lot harder, for one thing. But the way they do it is this is done by continuous counseling with the clinic staff. So the nurses, the technicians, they have dietitians, but they also teach everybody in the clinic to promote this low sodium message. And the other thing they do is they rarely give the patient saline. When their patients start to cramp or their blood pressure drops, they'll elevate their legs, they'll massage a cramp, but they're not going to inject more salt in them to make them more thirsty, like our patient DJ, and it happened to him. And so this prevents some of the thirst that it causes them to accumulate this extra weight. If you look at some of the results, they're pretty remarkable. I mentioned these, but I want to show you some of their data. So this is the first study. They had 67 hypertensive dialysis patients. They're all on blood pressure meds. Their average age 42, and they put them on this comprehensive volume control protocol. Let me just show you what happened here. So the body weight is in the green here. This is intra-dialytic weight gain in the red on this first graph. So their body weight went down after 6 months, which, this is a wasting population. You wouldn't necessarily think that's a good thing, but this is probably just fluid weight. They're drinking less, so their body weight goes down because they have less fluid on them. Because after about 6 months, they actually started to gain weight, and this is probably real weight. This is muscle mass and maybe even some fat mass. But we think that because their intra-dialytic weight gain went from 3 kilos right here on this axis, 3 kilos down to 2, and it was maintained for 4 years. So this is a real increase in muscle and fat mass, which is a healthy change. Let's look at their blood pressure. At the beginning of the study, they look just like we do in the United States. Their blood pressure is 170 over 100. Despite being on multiple blood pressure medications, they take them off the meds, they put them through the volume control protocol, and their blood pressure over the course of 6, 12, 24, 48 months is completely normalized, 120 over 80, just like you would see in a normal non-hypertensive person in the United States. This is a cardiothoracic index. This is a measure of pericardial effusion, also goes down, which indicates they have less fluid on them. So 67 dialysis patients, improved intradialytic weight gain, body mass, blood pressure, hemoglobin increase. So they're going to have more energy. Serum albumin levels, which is a marker of nutritional status, also improved. Only 4% of their patients needed blood pressure meds, and 0 had edema and heart failure, which is a common problem. So these are some of the healthiest dialysis patients you can imagine. Another thing, one of the things when you try to pull excess fluid off of a patient, I mentioned there's this condition known as intradialytic hypotension that is very common because when you pull all this fluid off, their blood pressure drops, and it drops excessively, and this causes all kinds of these problems I was talking about with cramping and ischemia to different tissues as well. And so intradialytic hypotension is a big problem that leads to some cardiac, there's some cardiac manifestations that are problematic with that. But when they do it in their clinics, they had 2 different studies that the prevalence of those with intradialytic hypotension was actually reduced from 18% down to 11 and 22% down to 7 in 2 different studies. And so they don't see an increase in the frequency of intradialytic hypotension like most of the rest of the world does when we pull off excess fluid. They actually see a reduction in intradialytic hypotension. And the primary reason why they think is, one, we don't just pull, in the United States, when we're trying to reduce excess volume, we just pull more fluid off, and they don't focus on restricting the dietary salt to reduce the intradialytic weight gain. And they also don't stop the blood pressure meds. And by doing these 2 things, it allows you to pull off the fluid without these side effects of the intradialytic hypotension and cramping. So I mentioned they're also associated with lower hospitalization and mortality. So this was a study, 218 patients for 4 years. They implemented this volume control protocol. Intradialytic weight gain, this is over 24 hours, went from 1.4 kilos per day down to 0.9. Blood pressure from 150 over 90 down to 120 over 80, basically. Only 9 of the 218 patients required blood pressure meds, and only 1 was hospitalized due to excessive volume. And this is a big problem normally in dialysis patients. Mortality rate's about 7% per year, and which is way lower than it is in the United States. And the lowest mortality was associated with a blood pressure between 100 and 110. If you look at data in the United States and most Western populations, the mortality, the lowest mortality is associated with blood pressure in most dialysis patients, 130 or 140. And there's a variety of reasons for that. But what this shows is that when you get the excess fluid off, a normal blood pressure is the safest blood pressure to have. So this is just showing the data. This is the percentage, the number of patients and what their average blood pressure was. The average blood pressure was somewhere around 120 systolic blood pressure. And mortality, this is all-cause and cardiovascular mortality, started to go up after their blood in those patients whose blood pressure wasn't controlled. So it just, again, suggesting a normal blood pressure is the protective blood pressure in a dialysis patient that's not volume overloaded. So another benefit of volume control is these patients just feel better. So the lower their intradialytic weight gain, so the less fluid they gain in between their treatments, the lower the ultrafiltration rate. This is a rate of fluid removal during dialysis. So if you can pull the fluid off more slowly, they just feel better. It's a more of a physiological situation that it's almost like they have better kidney function when you can pull the fluid off more slowly. So their intradialytic weight gain example, if it's high, the ultrafiltration rate is 1 liter per hour, which is faster than what's known as the plasma refill rate. And what that means is that when you pull fluid during dialysis, you're pulling it out of the plasma compartment and you refill, you have all this excess fluid around your tissues, intercellular space that refills into the plasma to help maintain the pressure. And if you pull it off too fast, you don't give time to refill the plasma compartment. So the blood pressure tanks and you get this interdialytic hypotension, ischemia to the heart, to the brain, which causes problems. So the result, interdialytic hypotension, ischemia, condition known as myocardial stunning, caused by ischemia to the heart, cognitive dysfunction because of ischemia to the brain, post-dialysis fatigue, sleeplessness. And I like to refer to this as the sledgehammer dialysis, because this happens in every, 3 days a week. They come to dialysis and they get the crap beat out of them by getting all this fluid pulled off of them, and they feel horrible. But if your interdialytic weight gain is low, so 2 liters as opposed to 4, you only have to pull off half a liter an hour. The refill rate is sufficient to maintain blood pressure, and they just feel better. Their blood pressure is more stable, drops a little bit, not a ton. They have less cramping, fatigue. And I think they're probably, I don't have great data on this, but they're going to have a greater capacity to exercise. They're probably going to be less inflamed. There's some data to support this because their system's just not in overdrive. It's a more gentle dialysis. It's going to allow them to have a more normal life. And it's this question, how do you lower interdialytic weight gain and chronic volume overload? Well, the primary way in which this can be done is by reducing salt intake to prevent thirst. At least that's a real good start. And so I've talked a lot about Turkey and versus the United States. It's a sort of a summary slide of how they control blood pressure versus how we control blood pressure. And this has, lessened for our practice of medicine in general in the United States and around a lot of the world. So blood pressure medications. In the United States, we give about 2 to 3 blood pressure medications per patient. Vasodilators, beta blockers, ARBs, ACE inhibitors, whatever. In Turkey, and there's some other regions too, it's not just this one town, they use this comprehensive volume control protocol where blood pressure meds are rarely used because they promote interdialytic hypotension. So when you remove fluid and you're on a vasodilator, then they can't constrict to maintain pressure. That's one example. Dietary restrictions. We focus on phosphorus and potassium, and this is nuts, grains, legumes, dairy, all that stuff. So they're very confusing and they're not effective. Whereas they focus on sodium to prevent the thirst. These are sensible restrictions that require eating less processed foods that are healthy for a variety of reasons. Their fluid intake policy, our fluid intake policies, we tell thirsty patients not to drink. They tell patients, drink as your thirst indicates, but restrict sodium to prevent the thirst. But if you're thirsty, you have to drink. Our dietary counseling, we have a registered dietitian that provides counseling on average 1 dietitian per 100 patients. They don't have a lot of dietitians either, but they've trained the nephrologists, the nurses, the receptionists, even the bus drivers at the clinics are taught how to promote this low sodium message. Cramping, interdialytic hypotension, we provide saline. So we stop removing fluid. They provide IV dextrose, which doesn't have the thirst stimulus that the saline does, and they massage your cramps and do things like that. And the results are very evident. We have hypertension in 80% of our patients, and they're still on 2 or 3 different blood pressure meds, versus they have normal blood pressure in 90% of their patients with 0 meds. The cardiovascular mortality is half of the US rate. So I asked you, where would you prefer to undergo dialysis? I'd prefer to do it in Izmir. And also, as an exercise physiologist, which patient population do you think has a greater capacity to exercise? One that has a lot of volume overload and all these different medications and all this post-dialysis fatigue, or one that feels a lot better and is a lot healthier? So if we want to rehabilitate our dialysis patients, I think this has to be a target. We've got to correct this volume excess in order to get patients healthy enough to exercise. So how do they get them to eat less salt? And this is where it becomes really relevant to a lot of other conditions as well, because getting people to eat less salt is challenging, not just for dialysis patients, for a lot of people. And the way they've done it in Turkey, they talk about immersing their clinics in a culture of sodium restriction. I love that terminology there, because it really encapsulates this comprehensive approach. And they don't just rely on their dietitian, it's mediated by the entire clinic staff. They're minimizing restrictions on phosphorus and potassium in most patients, unless they have overt hyperkalemia or phosphatemia. They really focus on the salt. And the rationale is if you can't have a single dietitian handle this problem, the clinic staff, the nurses, the techs have to be trained to deliver this message. I talked about the bus drivers are taught how to promote the low sodium message. We don't do anything like this. We have a dietitian and they have to talk to 100 patients. They have other responsibilities. They can't do this. One of the things we're doing, this isn't what they, but we've actually developed a workplace wellness program to teach the staff a little bit about, their nutritional issues and how to get them understanding better about their health so they can help facilitate our program. And in Izmir, this approach really relies on constant communication with the patients. Every time a patient comes in the clinic with elevated blood pressure and weight gain, they get a talking to by the staff. You don't tell them once, you tell them every day, and everybody has a consistent message as opposed to the dietitian telling them one thing and everybody else telling them something else. So the main message that they provide their staff, and what we're trying to do as well, and not just the staff, we're trying to do this with the patients' families. It's not about dialysis patients always think about fluid restrictions. If you don't want to gain weight, don't drink anything. But if you really, for it to be effective, you've got to really focus on their diet. Where's the salt coming from? It's coming from food that they buy at restaurants, and also, canned food, processed food, even things that look good, that has a lot of sodium in it. That makes you thirsty. That causes the fluid overload. That increases your blood pressure and plasma volume, puts a strain on your heart and arteries. It also necessitates an increase in ultrafiltration, or removal of fluid, which causes cramping and hypotension, which requires saline, which makes them more thirsty. So it's this vicious cycle, starting with salt in the diet. If you don't get rid of this, you're not going to get rid of the fluid overload. So some principles we use to guide the low sodium education. They do this in Turkey. We're trying to do this as well. There's, it's not inherently complicated, but we're trying to get our patients to shop more, trying to get the family involved as well. It's not just working with the patients. We're trying to get them, once they get them to the store, shopping, we call it shopping better, which is shopping for whole foods, liberalizing the dietary restriction on fruits, vegetables, nuts, grains, and all that stuff. Conducting grocery shopping tours. You get them to learn how to read labels. I'll talk about that in a minute. And getting them to understand that if you eat out, you're going to be eating high salt. It's almost impossible. So shopping more, shopping better, and eating out less, as opposed to what's done historically, which is giving them lists of foods that they can't eat. I just think this is a simpler message for them. I want to mention this 1 milligram of sodium per calorie rule. You can try this yourself. It's kind of a fun little rule where you look at a nutrition facts label. They hate reading nutrition labels, but this is a real simple one. Look at a nutrition, pick up any nutrition facts label on anything in a package. Look at the calorie number and the sodium number. Which one's bigger? If the sodium number 440 is bigger than the calorie number, this is indicative that it's probably a highly processed food. It's not a perfect rule, but it works pretty well. As opposed to here, sodium calories 300, sodium 130. This is a better choice. They don't like counting up milligrams of sodium, but they can tell if one number is bigger than the other. And this is something that it's helped explain how to shop better for a lot of patients. It's very easy. I kind of joke. I actually did do this. I taught my daughters and one of her friends how to do this. They hated it, but they were able to do it. Hazel didn't get it. She was like 3 at the time, or 1, or whatever she was. But it can be done. You can teach anybody this rule, how to shop for low sodium using this rule. So one of the things we tried to do throughout the last few years is trying to mimic the Izmir volume control protocol. And we've done this in a couple of different studies now, where we want to see if we could achieve the same benefits they did. And our first attempt at this was a trial in which we had 23 patients that completed a 6-month volume control protocol modeled after Izmir. So we had weekly counseling to reduce their dietary salt intake and intradialytic weight gain, blood pressure medication deprescribing, and this persistent reduction of the post-dialysis weight. Those were our sort of methodology for getting rid of their excess volume. Problem we quickly realized was that the patients weren't listening to us when it came to the dietary salt restriction. The physicians were hesitant to reduce the medications, and the nurses refused to reduce their post-dialysis weight because the patients were cramping, in part because the physicians wouldn't remove the meds and the patients wouldn't reduce their salt intake. So we ran into a lot of problems immediately, but we still had some benefit. They listened a little bit, the physicians listened a little bit, the nurses listened a little bit. So we did see a significant reduction in volume overload at 6 months. And here's the data. Total body water went down. Their extracellular fluid was down, intracellular fluid wasn't, but their volume overload was reduced. And there was also a short-term reduction in this intradialytic weight gain. It went from 3 down to 2.7 and kind of stable after that. But it wasn't what we were hoping for. It wasn't the robust benefits they see in Turkey. At the end of the day, we did not get buy-in from the patients, the clinic staff, to the extent we needed, because we are researchers coming in off the street working with the patients, and we didn't get total clinic buy-in. So, but it was a first step, and it's promising in many regards. What we decided to do is just really back off the comprehensive approach and really focus the first thing on, let's see if we can get their salt intake down a different way and if there's benefits. If we can get their salt intake down by feeding them for a short time period, it's kind of a proof of principle. We want to get their salt intake down, see if we can reduce intradialytic weight gain, and if that's going to have improvements in blood pressure as well. So we use a commercial vendor called Mom's Meals. We had 20 patients, and we set up the protocol. We just kind of watched what they ate for 4 weeks and looked at their intradialytic weight gain. And then weeks 5 through 8, we delivered 3 low sodium meals to their home. And the primary outcome is change in intradialytic weight gain. And when we did this, so intradialytic weight gain here was about 3 kilos per 48 hours, and it went down immediately as soon as we started reducing their salt intake. So this works. You reduce salt, intradialytic weight gain goes down, and the ultrafiltration rate went down because they were gaining less fluids. You had to pull less off. And it was very consistent. If you look at this, and this is the observation month versus the month we're feeding them, almost everybody, a couple people were flat, but most everybody in the trial reduced their intradialytic weight gain significantly. Blood pressure also went down significantly. They weren't as thirsty as xerostomia as dry mouth. They don't need as much candy because they don't feel their mouth is as dry. So this is a promising preliminary study, but the fact of the matter is we know we can't feed them forever. So can we change their habits in the long term? And the idea is that if they see these benefits for a short time period, then they're going to be more likely to listen to our low sodium education. So we set up a study to test this. It's 5-month RCT or low sodium intervention. So in month 1 and 2, we provided meals and low sodium education. Then in month 3, 4, and 5, we continued the low sodium education, but they had to provide all their own meals, make their own meals or what have you. And we had a waitlist control that received meals in months 6 and 7. So our primary hypothesis that the meals after 2 months, we're going to reduce intradialytic weight gain, and then we can sustain the benefits because they're going to feel better. We can sustain the benefits for up to 5 months. Well, the secondary outcome, so we don't have this data. I can talk a little bit about it anecdotally, but I want to mention the secondary outcome here was that the meal provision is also going to reduce muscle sodium accumulation, which I'm going to start talking about in just a minute. So this is an ongoing study. I want to show you some of the data related to the muscle sodium. So first of all, what is salt doing in our patients' muscles? And this also gets at some of the things that are relevant to a lot of other chronic conditions, because it's not just in dialysis patients. In a lot of chronic diseases, there's sodium accumulation in muscle. So as we age with different diseases, salt does accumulate in our soft tissues. It's kind of led to a new understanding of sodium metabolism, where classical physiology teaches that dietary sodium is excreted in the urine in 24 hours. But this actually is not very accurate. What happens instead is dietary sodium is temporarily stored in our tissues after we ingest it. And we know this because we can put people in a MRI scanner with a sodium coil and detect this excess sodium. And what's happening is the immune cells, after you eat sodium, immune cells, the sodium goes into these tissues. Immune cells will detect this stored sodium and promote lymph vessel expansion to drain the salt back into the plasma and goes out into the kidney, but it doesn't happen in 24 hours. And with age and with chronic disease, the salt tends to accumulate over time. What impact does it have on tissues, your skin? Because it accumulates in the skin, skeletal muscle, brain, and other tissues. And it happens in diabetes, chronic kidney disease, multiple sclerosis, hypertension, muscle wasting, cachexia. This just shows by age, as you age, muscle sodium goes up. Chronic kidney disease compared to controls, pre-dialysis CKD, it's higher. Dialysis, hemodialysis, peritoneal dialysis, sodium accumulates in the skin, skeletal muscle. And here's an MS in the brain compared to controls. As multiple sclerosis progresses, salt in the brain increases. So this is relevant to a lot of different conditions, and it's thought to be causative in terms of the progression of the disease. Just want to mention also, I had to take this slide from a talk I saw. There's also some indication, I've been published, that the higher tissue sodium is associated with reduced survival and quality of life. This is in dialysis patients. Those with higher sodium, lower sodium versus higher sodium, the survival is better in those with lower sodium. Question I'm really interested in as an exercise physiologist is if the excessive sodium contributes to muscle wasting and dysfunction in our dialysis patients. We know that compared to controls, dialysis patients have lower contractile tissue. The relationship between the contractile cross-sectional area and muscle force is diminished in dialysis compared to controls. They have enlarged fibers that indicate edema. They have enlarged mitochondria. So we have all these sort of phenotypes. We don't know if it's associated with the sodium accumulation, but we think it possibly is, and we're doing studies to try to address that. So the way we do this is you can detect, as I mentioned, sodium in these soft tissues using sodium MRI. And so what we do is we put person's cap inside of a sodium coil, then they get put into the MRI machine. Here's a person doing some plantar flexion exercises, but normally we're just looking at without exercise. But when people think of MRI, they think of proton MRI that provides a structural image, and we've got a structural image and we can see the different muscle beds that we can analyze. And then with the sodium signal, we get a total sodium signal, and we can distinguish the salt in the cell versus extracellular sodium. And so I just want to briefly show you results from a 2-month meal feeding study where we looked at the change in muscle sodium in response to 2 months of the low sodium meals. And this was conducted, we conducted sodium MRI in the calf muscles before and after these 2 months of the meals. And the results are it's only 7 people so far, but we are seeing a trend of reduction in the muscle sodium. So in these different muscle beds, it's pretty consistent. If you look at all the muscle beds on average, we've got a trend for reduction in muscle sodium. And there doesn't appear to be as much change in extracellular sodium as the intracellular sodium. Most of the change appears to be intracellular, at least initially. So what we're really interested in finding out is if we can reduce, once we get everybody through this, one, if the muscle sodium goes down, where it goes down, and will you improve improve physical function if you can get rid of the salt? We have some reasons to think that might be the case. And also, we're exercising our patients during dialysis. When you do that, you're perfusing the skeletal muscle more. We're hoping that interdialytic exercise can actually drive salt out of the muscle as well. But those studies are ongoing. I am getting close to the end here, so we've got a few more minutes to finish up. Just talk a little bit about next steps. We already know that providing the meals is not working as well as we want. Our counseling wasn't working. Now we're providing meals to the patients. The salt intake isn't getting down as much as we want. There's some significant meal fatigue with these meals we're providing from the commercial vendor. And once we get rid of the meals, or once the 2 months is up, their sodium intake goes right back to what it was by 5 months. So we're not changing their habits with our current approaches. So we're trying to improve our nutritional education approaches and doing this a couple different ways. What we really have grown to recognize is that we need to teach people how to shop and cook. We can't just give them lists of foods they can't eat. We can't even just give them meals and hope they realize the benefits and then start changing things. We've got to get on the ground floor and teach these guys how to shop and cook and even grow their own food. We're doing this a couple different ways. We're developing some virtual reality based grocery store shopping tour that I'll talk about in just a minute to help them teach them how to shop. We got plans for developing a culinary medicine course to help them teach them how to cook low sodium, and developing we're trying to build a research a teaching garden like you guys have one at UIC to help teach people how to grow their own food if they're willing to do that. But we're trying to do a lot of things. These are just a couple examples. It's comprehensive nutrition education is what we really need for any of this to matter. Just to get some idea of where we're going with this, the virtual reality I mentioned. We did virtual reality application related to mindfulness meditation, just as a proof of principle. The idea here is that we know these dialysis clinics are very depressing places. Patients have a lot of time, so we developed this VR-based mindfulness program. It's related to positive psychology for reducing depression, and our goal, we thought, was to treat the depression these patients have from being on dialysis prior to starting a lifestyle intervention. And this might improve their compliance if they're less depressed. They may exercise more. They may decide, better diet is a good thing for them. And the second VR program that I mentioned, we're developing this low sodium education lab that provides a comprehensive and fun nutritional education program that's focused on low sodium and volume control. Just to show you, our VR mindfulness program was a 5-week program, reduced depressive symptoms. So they liked doing the VR. So our next step is what we found out was that the VR intervention was feasible to deliver. The patients liked it, and we now have a Rosalba Hernandez, who's at UIC now, is a collaborator of mine. Some of you may know her. She's got an NIH grant that I'm associated with to develop a 5-module VR positive psychology app and testing this in dialysis patients. We're working on now the VR is developing and testing a low sodium education program focused on low sodium shopping. So we're developing 5 VR modules related to meal planning, label reading, the grocery store tour, food storage tips, and cooking tips. The goals of this program are to gamify and simplify the low sodium education, make it more fun, reduce chronic volume overload, and hopefully also reduce muscle sodium. We've got a new grant to do that. So just to wrap things up, summarize and conclude some of the things we talked about and why it's relevant to all of you. Well, first of all, hemodialysis patients, I hope you understand from what I mentioned, they're very sick. They're difficult to work with. And if we want to improve their health and quality of life, we need some comprehensive interventions. The simple lifestyle interventions don't work. I've learned that the hard way. But most clinical trials in dialysis patients fail. But we know that comprehensive volume control is something that works. 90% of the patients in Turkey that I talked about have normal blood pressure with no meds versus 10 to 20% in the United States. Why is this not standard of care? Why can't we do what they're doing over there? Because the implementation of something like this requires a clinic buy-in and patient willingness, and that's not happening at this point. There's a lot of benefits of sodium restriction and volume control specific to dialysis, but sodium restriction related to a lot of conditions. It may reduce tissue sodium accumulation. It may improve physical function if we can do this. You have less salt in the muscle. Sodium restriction may also have anti-inflammatory effects. And I didn't talk about this, but there's evidence that it improves gut microbiome. And sodium restriction is therefore relevant to aging and almost every chronic disease that you can imagine. But the implementation of these sodium restricted diets really requires a lot of work, but it can be done. Izmir's shown it, and we're trying to do some things to mimic what they're doing and do some things better. That requires education on how to grow, shop, and cook for low sodium, as opposed to just telling people what not to eat. And with that, I hope I left a couple minutes here for questions. I appreciate